My name is David Kooby. I'm a surgical oncologist at Emory University School of Medicine. I specialize in complex gastrointestinal surgery and focus on upper gastrointestinal tract. I'm full professor of surgery. I am the vice chief of staff at the Emory St. Joseph's location and the surgical lead for the northern arc in the Emory system. In that situation, if they have localized disease or regional disease and it hasn't spread beyond the confines of the liver, then they may be candidate for some type of liver-directed therapy. The liver-directed therapy could be as minor or simple as a percutaneous ablation, or it could be as dramatic as a liver transplant. And so as a surgeon, my particular areas of expertise is in liver resection, and we have colleagues who do liver transplantation. And it's really not a competition. We evaluate patients based on age, based on physical health and vitality, as well as the quality of their liver to determine which option is better. So if you're comparing resection, which is going to be removing part of the liver and leaving the remaining remnant of the liver to grow and recover versus actually removing the liver and doing a transplant, well, liver function is one of the biggest aspects that you have to consider, and the extent of tumor is the other. So liver transplantation is less ubiquitous than liver resection, right? You can remove part of anybody's liver and you don't need anybody else involved. However, for a transplant, you obviously have to have an organ to give to that patient who is having their liver removed. So in that circumstance, that is a limited, that's a limited resource. We don't have livers just waiting around. So we have to really select our patients well. So in the late 1990s, a paper came out from a group in Italy. The lead author was Massafaro, which was the first paper that demonstrated a true benefit to using transplantation for a very select group of patients with liver cancer. And this was known as the Milan criteria. So patients who show up who have liver dysfunction from chronic liver disease, in this day, either from non-alcoholic steatohepatitis or from hepatitis C, which are going to be the most common causes. If they have one tumor up to 5 centimeters in size, or if they have multiple tumors, you cannot have more than 3 tumors, and none of the individual tumors can be greater than 3 centimeters in size. And so based on that criteria, now you have a selection criteria for determining if a patient's even a candidate for transplant. But there are many other factors that are involved. They have to have good support. They have to be able to, handle this in terms of mental capacity, mood. They have to be clean of any substance abuse. It's a whole process they have to go through. In addition, their tumor has to be somewhat manageable to get them to a transplant. If I meet a patient for resection, I can book them next week. But if they're going to have a transplant, it's probably going to be a minimum of 3 months before they actually get in the door for that transplant. So the tumor, the time on the tumor is ticking during that period. So for resection, we have to determine if the liver quality is good enough. If somebody has a healthy liver, and I'm going to remove a portion of the liver, I can remove maybe up to 70%, provided I do it correctly, leave good blood supply and good biliary drainage. Now, if the liver's not healthy, that number could drop to 10% or even less. Even just opening their belly to do a liver resection could put them into florid liver failure with ascites, problems with their wounds, and mental status changes and death. And so based on the liver quality, that'll be a big determinant as to whether a resection is even possible. So when we're looking at those two options, patients who have larger tumors with better liver quality function are going to be more amenable to resection. They'll be outside the transplant criteria that I mentioned earlier. And if their liver quality is good, then resection is a better option. However, if somebody has significant fibrosis of their liver, they're not going to do well with a major operation unless it's removing the liver and replacing it entirely with a better functioning liver. Those patients are going to do better with transplantation. So it actually is quite a collaborative effort. And at our institution, we have a weekly conference where we discuss these cases as a team and determine which sort of path they will take.